Welcome to my scientifically informed insider look at mental health topics. If you find this video to be interesting or helpful, please like it and subscribe to my channel. Hello, this is Dr. Grande. Today's question asks if I can take a look at a case study that features a sudden gain. So this is a dramatic result that occurs from one session. Now, a case study is when a clinician or several clinicians wants to document the interaction between themselves and a client. This is done for educational purposes with the client's consent, and information is changed, of course, in the actual case report. Some of the details are changed, the person's name is changed, but in theory at least, the clinical essence remains the same. The case study I'll be reviewing here looks at major depressive disorder, the use of cognitive supportive therapy, which appears to be a mix of cognitive behavioral therapy and person-centered therapy, and it looks at the concept of sudden gain. Sudden gains are a really interesting concept. Every counselor has seen them. Both clients and counselors understandably want them to happen, but nobody knows how to consistently replicate the experience. If counselors knew how to do that, they would do it all the time. Every counselor wants their clients to improve, and of course, every client wants to improve. In my experience, I've encountered many counselors who count on sudden gain, like it was their main mechanism for helping people to improve. They're always looking for that magic moment, and they struggle when clients progress normally through treatment. That is, when clients improved at the expected rate as opposed to massive improvement that happens in one session. That moment when a client's symptoms decrease seemingly out of nowhere has been called the moment of genius, which kind of makes it sound like the counselor did something amazing, but in my experience it's usually the client who does something amazing. They realize something about themselves and about their symptoms that help them to make a sudden improvement. I've also seen another situation with counselors in terms of sudden gain, and that's the situation where counselors never expect a sudden gain. So when a client does improve kind of quickly, the counselor is skeptical. They don't know what to do. They're so accustomed to counseling being a very long-term process with gradual gains, they can't adjust well to clients who improve quickly. These counselors often view quick improvements as not durable. That is, they're worried the improvement might be dramatic, it might seem significant, but it won't last. Actually, research shows that successful critical moments in counseling do predict long-term maintenance of the gains. So usually, a sudden gain will stay in place for quite a while. Now, this doubt about the existence of sudden gains, I've seen this particularly often with counselors who have been seeing the same clients for several years. They've tried a lot of different things. Some symptoms have decreased from time to time, but then the symptom severity reverted back to original levels. So it's like the counselor doesn't want to get too excited when the symptoms seem to dissipate, which in a sense is very understandable. It does seem unrealistic to treat somebody for 2, 3, 4 years or more, and then in one session, something amazing happens. It's not like the counselor should just say, well, okay, it looks like you're good after all those years. Success. I'm just going to walk away. Healthy skepticism is good. A lot of times when we think we see dramatic improvements, they are temporary. So we have to make sure that the sudden gain, this massive improvement, is real. It's that kind of sudden gain I talked about before that tends to be durable. And I think a lot of the times when we look at these improvements that happen quickly that are durable, it's those where there is a significant change in the client's philosophy, and this case study touches on that. I think the balanced counselor needs to be open to progress made in critical moments, but also be realistic about the course of disorders. For example, with major depressive disorder, we know this disorder is cyclical. Symptoms tend to come and go. So if a client is not in a major depressive episode, simply because that's the cycle of the disorder, a counselor would not want to assume that the reason the client is not depressed is because of a sudden gain from one counseling session. The more likely explanation is it's just, again, part of the cycle of the disorder. So with all that in mind, let's take a look at this particular case study. The client in this case was a 61-year-old divorced Caucasian female. I will call her Eileen. She presented with a history of major depressive disorder, MDD, and attention deficit hyperactivity disorder, ADHD. She had the inattentive type of ADHD. She reported a variety of symptoms during assessment: trouble sleeping, low energy, feelings of guilt, loss of concentration, no enjoyment from eating, memory problems, and she felt anxious and irritable. Her family members asked her to stop driving specifically because of the concentration and memory problems, and this made her more dependent on her daughter. This also was a reason she was frustrated. Eileen's medical history, which of course is normally collected as part of a mental health assessment, included osteoarthritis and fibromyalgia. So the pain from these conditions was also contributing to her mental health distress. The first major depressive episode that Eileen had occurred when she was 15 years old. She was intermittently treated with medications for depression for several decades after that. We see that the psychopharmacological treatments really didn't result in success. Eileen had attempted suicide 3 times between the time she was diagnosed and when she was in her 30s. At the time of intake, the client was experiencing a major depressive episode, so she was in an MDE at that time, and she was worried about her future. She believed that her mental capabilities would continue to decline and she wouldn't be able to maintain any level of independence. Eileen owned her own business. It was a graphic design business, but it wasn't doing well, and she also had some relationship challenges. So it sounds like everything was kind of piling up on Eileen. I've seen this many times in my clinical experience. Too many things are happening at one time, and people get overwhelmed. There's a sense that even if they could fix 1 or 2 things, they could never fix enough of the things that are bothering them to make a significant difference. So there's really a good deal of hopelessness and worry in these types of situations. Now, this case report covers the psychiatric treatment and the psychotherapeutic treatment. It provides a lot of detail about what medications were used and what dosages. Now, I'm a PhD. My PhD is in counseling. I'm not a physician, but I found this section interesting still. One thing that really stood out to me when reading this part of the report was how long it took for someone to recommend Eileen be treated by a psychotherapist. So it really seems like the psychiatrist treated her mostly in the beginning, and we see the psychotherapy more toward the end of her treatment. Now, there may be other things that I don't know that explain what happened in this particular case. For example, maybe Eileen didn't want to initially see a psychotherapist. However, I see this occur a lot in general. Sometimes psychiatrists wait too long to make the referral to a counselor or other related professional. And I've also seen this happen the other way too, where counselors wait too long to refer clients to see a psychiatrist. Another part that really stood out to me was that her medications were changed several times during the course of the cognitive supportive treatment sessions. So this is just how the world of mental health treatment works, but it does make it confusing in terms of figuring out what the active ingredient was, so to speak. What caused the improvement? Was it the cognitive supportive therapy? Was it the medications? Was it a combination of both? It's really hard to tell. Now, taking a look at the psychotherapeutic treatment, Eileen was receiving what the clinicians here called cognitive supportive therapy. She received this for the first 5 months of treatment, and things weren't really going well. Eileen only attended 5 sessions in that time. She had 7 no-show missed appointments. Then some changes were made to her medications. Over the next 6 months, she attended 11 therapy sessions and didn't have any no-show missed appointments. Now, it was at this point when the critical session occurred, about 11 months or so into therapy. After this critical appointment, which I'll talk about in a moment, we see the client would attend another 41 sessions over the next 23 months. So what really stood out for me before this critical session anyway was how infrequently the client was being treated, how infrequently Eileen was seeing the clinician. The clinician was trying to treat Eileen twice monthly, but of course the missed appointments changed the frequency quite a bit. I think it's better to start out with once a week and then move back to every 2 weeks or twice monthly, which of course is a little less frequent. But I understand that clinicians approach this issue differently. As I was reading this report, I was a little surprised that the therapist was using, again, what they refer to as cognitive supportive therapy instead of cognitive therapy, CT, which of course is indicated for major depressive disorder. But the report explains that the cognitive therapy techniques were attempted but not well received by Eileen. So it sounds like there was this mix of cognitive techniques and supportive therapy. Again, they just call this cognitive supportive therapy. So it's hard to tell exactly what the mixture would be, but it sounds like it was much more supportive with very little of the cognitive strategies involved. Now to take a detailed look at that critical session. What happened during that critical session? So during this session, Eileen reported that she felt bad about herself, she felt useless, and she believed that because she felt useless, this was causing her to feel depressed. Here we see an opportunity that the clinician capitalizes on. There's a switch back to the cognitive therapy techniques, so a movement away from the supportive element toward the classic CT techniques. There were two really important interventions in this session. First, the clinician had Eileen make a list of all the ways that she is useful and all the ways that she is not useful. This is done to kind of break away from the all or nothing thinking, which is a cognitive distortion that is somewhat common when working with people who have depression. The second technique involved the clinician asking Eileen if Eileen would see her best friend as being useless if the best friend was in the same exact situation as Eileen. The same life circumstances, the same mental and physical limitations. Eileen answered no. She wouldn't see her best friend as being useless. This is where we really have the critical moment. Eileen realizes that her labeling of herself as useless is inconsistent with her own belief system. She believed that all human beings had intrinsic worth that does not vary based on the circumstances. If her belief was correct, then Eileen would not be subject to the changes in her worth. But that's how she was viewing herself. Again, viewing herself as useless. This was the inconsistency that was exposed in this moment. This was the moment of insight. Eileen realized that she needed to apply her value system to herself in order for the value system to be consistent. She returned to the next session saying she had a new lease on life. She noted that something really clicked during that critical session. She was able to understand that her worth as a person was not connected to how useful she was to other people. She believed that she had a life-changing therapy session. I find this next part of particular interest. She told her psychiatrist a little bit later that she had one of those earth-shattering moments that counselors and clients live for. But at the same time, she attributed much of her improvement to a recent increase in one of her psychotropic medications. So this speaks to that difficulty I talked about earlier. What's actually causing the change? It sure seems like the therapeutic intervention made a big difference, but maybe it was the medication. Now we find out later in the report that Eileen actually did attribute her success to the cognitive behavioral intervention. She believed that the medication change had a significant impact on her ability to think clearly. So both types of treatment helped, just in different ways. When she returned to the therapist, she continued to make statements consistent with feeling better. She felt like a new person. She felt like she had more control over her life. She had more initiative. She was amazed by this idea that she used to believe things that were not actually true. And she was also applying the same logic, the idea that she might not have been correct about everything, to other situations. I think this is one of the most important moments and important lessons from this case study. Cognitive therapy isn't just about confronting a belief with logic and proving that the belief is true or false. Rather, it's about learning how to apply logic over a wide variety of situations. And that's what Eileen was doing. She learned a more efficient and logical way of thinking that was now affecting other parts of her life. So she gained an ability, not just an awareness of a fact. Essentially, Eileen was able to become a flexible and critical thinker. She was willing to evaluate and reconsider her own deeply held beliefs. In my opinion, this is one of the highest levels of achievement for someone in cognitive behavioral therapy. In the following months, Eileen reported that she was continuing to do well. She was financially dependent on her daughter, but she didn't hate herself anymore. She reported that during stressful times, she relied on her new worldview, that nobody's perfect and everyone has value. Something else I find particularly fascinating here, Eileen was treated for another 23 months after the critical session, but the therapist did not move back to cognitive therapy techniques after that critical session. So no more challenging beliefs, no direct advice to change behavior, no more homework assignments. The clinician did, every once in a while, help the client to explore that shift in thinking that took place during that critical session and discuss the positive consequences of it. But I find it curious that there was no return to the cognitive therapy techniques. I think I would have continued to build on the client's new philosophy, the new way of thinking, rather than move away from those techniques. Now, that's just my thinking on it. It appears that things worked out really well in this case, but in many situations, it's better to continue with the cognitive therapy strategies and not just kind of sit back and hope that they take off on their own. It is important to note here, of course, that the clinician could have had reasons for doing this that were not explained in the report. So this is an interesting case, and it shows how psychotherapists, like counselors and other related professionals, can work together with psychiatrists. Looking at this case, the therapy facilitated a breakthrough moment of adopting a more logical thinking style. But it was the medication that helped the client to attend therapy reliably in the first place and to have improved concentration. And both of those gains are important for getting the most out of cognitive therapy. You have to be there to receive the therapy, and you have to be able to concentrate to benefit from it. At least you have to be able to concentrate to some degree. This case report features a good example of two mental health disciplines working together toward the same goal. Eileen felt supported and cared for by all of the mental health professionals involved in her care, and that probably explains some of the change as well. I know whenever I examine case studies, there's always going to be a variety of opinions. Please put any opinions and thoughts in the comment section. They always generate a really interesting dialogue. As always, I hope you found this case study on sudden gains to be interesting. Thanks for watching.